What's up, YouTube? My name is Matthew Smith. I'm the Paramedic Program Coordinator here at LaGuardia Community College, and we are here today to talk about the upcoming EMS Symposium we have, and specifically one part of that symposium, which is our New York City REMAC exam prep, or NYC rep class, that's going to be taking place at that symposium. It's going to be on April 28th from 8 a.m. to 5 p.m., and we'll have some info on how to register at the end. But the purpose of this video is just to give you a quick preview of some of the things that we're going to be talking about that day. So, as you know, the New York City REMAC exam is an extremely challenging exam. About 1 in every 4 people who take it are not successful in passing, and that includes active paramedics who are working in the field. So, if you're preparing for this exam, you definitely want to take it seriously. You do not want to put your livelihood on the line and have a 1 in 4 chance of not being able to work or make money. So, what we're going to talk about today in this preview are the principles of protocol interpretation that are at play in the New York City REMAC exam. So, I think a lot of times people struggle when dissecting an exam question to know how far to read into it. So that's what this is kind of all about. So the first thing we're going to start with when it comes to interpreting protocols is the plain language of the protocol. So if the protocol says to do something in a particular order, we're going to do it in that order. We're just going to start with the plain language. We're not going to try to read into what the protocol doesn't say. So don't read into the protocols unnecessarily. However, you do want to read the entire protocol, including all notes. So when we say plain language, what we really mean is the plain language of the whole protocol, and you read different parts of the protocol in context with the rest of it. For example, the smoke inhalation protocol, 500A and 500B, there's a note on that protocol. It's actually extremely important. What that note says is that if you have more than 5 patients, it has become an MCI, and in order to do any of the treatments that would otherwise be a standing order, you actually have to have a class order from online medical control. So that note becomes extremely important. Other examples of important notes are the nausea vomiting protocol, which says on the kind of header of that protocol for adult and pediatric patients. It's found in the section of the protocols that is generally the adult medical section. However, that protocol actually does apply to adult and pediatric patients. So you may not realize it, but you can't start an IV on standing orders for a pediatric patient having an asthma attack. You actually can start an IV on standing orders for a pediatric patient who is nauseated or vomiting. Okay, another principle that we want to get out there is to use the most specific protocol on point. You're going to have patients that could fall under multiple different protocols. Here's an example. You have a pediatric patient who is hypotense. That patient, by default, I think you would go to the pediatric decompensated shock protocol, and that's a perfectly defensible decision to do that. However, what if I told you that that patient is hypotense, having been just pulled out of a burning building, having been exposed to smoke? At that point, we're no longer going to use that pediatric decompensated shock protocol. We're going to jump over to the smoke inhalation protocol because that is more specific to that patient. So where you have 2 protocols, what you want to ask yourself is, which of these protocols is more specific to this patient's particular presentation? Now we get into one of the areas where people can get into a lot of trouble, certainly in the field and also on the exam, and that's clinical judgment. So everybody's favorite line in the protocols is on the very first page, where it says that these protocols are to be used in conjunction with good clinical judgment. So the question is always asked, what does that mean? How far can I get with clinical judgment? Well, here's some basic principles for that. First of all, evaluations must be done unless there are extenuating circumstances present. So if you have a patient with chest pain, good clinical judgment isn't going to excuse you from doing a 12 lead on that patient, provided that there's no extenuating circumstances like a guy's chasing you around with a gun or something. If a patient has chest pain, you need to be doing a 12 lead. There's not really a risk to that treatment. There's not really a downside to that treatment. When it comes to treatments, though, so a treatment being aspirin, nitroglycerin, and, medication administration, CPAP, that sort of thing, treatments are generally may be done or may be deferred, provided you have an articulable reason for deferring that treatment. If you have a patient with, let's say, chest pain, but that chest pain is occurring following having been in a motor vehicle accident and having hit their chest on the steering wheel, then you would not make a presumptive diagnosis of myocardial ischemia on that patient, and therefore you wouldn't be giving that patient aspirin, especially since that patient may be having some bleeding going on, and so you wouldn't want to exacerbate that. So treatments, you have some leeway with clinical judgment. Evaluations, should you do a 12 lead on that patient who just got out of a car accident and has chest pain? Absolutely you should, absolutely. Does order matter? Well, yes and no. So there's certain circumstances where order is, it's clear from the context of the protocol that order is very important. So one example of this is the anaphylaxis protocol, where it specifically says to simultaneously administer IM epinephrine as well as perform advanced airway management if the clinical situation calls for it. So in that instance, it's very clear that those two treatments are intended to be done first and simultaneously. However, order doesn't always matter, and the order of treatments is one area where your clinical judgment can come into play. An example of this is the BLS Burns protocol. On the BLS Burns protocol, believe it or not, the entry for stop the burning process is actually, I think, listed third, which is behind perform airway management. If you have a patient that is on fire, obviously you need to put out the fire before you manage their airway. So that's where your clinical judgment gets to come in play, where the protocol doesn't explicitly spell out an order and you can kind of determine which order you're going to go in. The last principle of protocol interpretation that I want to give you is this one, which is that protocols are not intended to be combined unless it explicitly states in the protocol that you should jump to another protocol. So here's an example of protocols where you can combine. That nausea vomiting protocol that we mentioned earlier, you can actually combine that protocol with other protocols because it says in that protocol, consider and treat underlying causes of nausea vomiting. Therefore, you should do that 12 lead if they're nauseated and of a cardiac age or have history suggestive of a cardiac complaint. And you should evaluate them for myocardial ischemia before you jump right ahead to the ondansetron. However, an example of a protocol where it doesn't say to combine with other protocols is PEA asystole. And this is one where people tend to get in a lot of trouble. So there's this idea out there that PEA asystole is like the ultimate altered mental status. Because, of course, any patient in PEA asystole also does have an altered mental status. They're not going to be alert and oriented while their heart isn't beating. However, we know that these protocols are not intended to be combined. And the reason we know that these protocols are not intended to be combined is that both of those protocols state to give D50. D50 is in both protocols. If the intention of the drafters of the protocols was that we be able to combine those protocols and use treatment modalities that are listed in either of them freely, they wouldn't have needed to put D50 in the PEA asystole protocol because it would have been redundant with altered mental status. However, they did choose to list D50 in the PEA asystole protocol, and notably they did not list naloxone, which is that other treatment under altered mental status. So there's folks out there that'll say, well, PEA asystole is really the ultimate altered mental status, and therefore we can give naloxone in PEA asystole under that protocol. Actually, you can't, because the PEA asystole protocol is more specific to the patient that you have. Just like we said up here, use the most specific protocol on point. PEA asystole is more specific to what you have going on than is altered mental status. Altered mental status describes a wide swath of patients, from people who have a pulse to people who don't. PEA asystole is much narrower. It's only those patients who are pulseless and not in VTAC, VFib. So you should not be giving Narcan on standing orders for your PEA asystole patients. All right, so that's a preview of the sort of thing that we're going to be doing on test day. Other things that we're going to be doing, we're going to be going through practice questions, talking about how to dissect a question. We're going to be giving you a mathematical formula to determine whether you are on pace to finish the exam on time. We're going to be doing a live review of each and every protocol, and we're going to be pulling out the various pain points in those protocols, the things that tend to trip people up, so that you are well prepared and well briefed on anything that you may see coming up in that REMAC exam. So how do you get the full presentation? How do you get everything? Well, let me show you. You're going to go to bit.ly/EMS, all in caps, and then capital S, Symposium. And that will pull up our Symposium registration page. You go right on there. If you're doing REMAC prep, you are eligible for the special price of $75 only. That $75 will get you in for the day. It'll get you the full REMAC prep class. It'll get you 2 hours of call review at the end of the day. It gets you breakfast. It gets you lunch. As well, we're going to have free parking there that day. We are going to have employers. We are going to have employers available there to network with. We're going to have vendors there selling EMS gear. We've got some awards to give out. And we have a big keynote address with Dan Limmer of Limmer Education, who's a nationally known educator. So certainly would encourage everybody who's watching this to sign up for that symposium, get a ticket, and hope to see you there for our full REMAC prep class as well. Just to throw this out there, when you attend this class, the REMAC prep, you're going to get 2 full REMAC exams that are modeled after they have the same question breakdown of the actual REMAC exam, including scenarios. You get 4 full scenario sets of 10 questions each. So you can actually take those exams home, you can practice them, and use them to make sure that you are ready to go on test day. Our results so far with this class have been excellent. Everybody who's spoken to us, who's taken the class and then taken the exam, has done extremely well. So we would love to add you to that group of people. All right, that's it, guys. Thanks for watching, and have a great day.